So our next speaker is Matt Smith from the Mass General. Matt has had a long-term interest in the role of bone agents in protecting against bone events, and interestingly enough, now they have an anti-tumor effect, which we'll hear about. Matt.
You may have to wait on the anti-tumor effect results for a few weeks, but I'll do my best to tell you what I can. My thanks to Bruce and STO for this opportunity to discuss bone-targeted therapies for prostate cancer. This has been an area of tremendous progress and promise over the past decade. My presentation will really focus on three areas: Osteoclast targeted therapy, radiopharmaceuticals, and then I'll very briefly comment on the role of targeted therapy and its impact on bone with exciting new information about Cabozantinib. Bone metastases are a major cause of morbidity and a disproportionate cause of mortality in men with advanced prostate cancer. The risks of bone complications span a spectrum of conditions, from osteoporosis and fractures related to age and therapy to the most feared complication of prostate cancer, castration-resistant bone metastases. And in the interest of time, I'm going to focus my comments on treatment and prevention of bone metastases. We'll save the issue of osteoporosis for another time. First, a brief few words about the biology. Normal bone remodeling is a coupled and regulated process that involves a coordinated activity of osteoclasts, which resorb bone, and osteoblasts, which result in new bone formation. And homeostasis between osteoclasts and osteoblasts is necessary to maintain the integrity and strength of bone. In the case of bone metastases, this process is co-opted by tumor. There are complex reciprocal interactions between tumor cells and bone. Prostate cancer cells have potent effects on osteoclasts and osteoblasts, which result in marked increases in bone remodeling. This is a pathologic process which has the net effect of new bone formation, but this bone is disorganized and biomechanically weak. In turn, the bone microenvironment, the many growth factors elaborated by osteoclasts and osteoblasts, have potent effects on tumor cells, and this is very much in line with the earlier comments you heard from Dr. Evstathiou about the microenvironment. In this case, we're talking about the bone microenvironment. The clinical complications of bone metastases are well known to this audience. Bone metastases from prostate cancer are associated with pain, fractures, spinal cord compression, and the common need for other interventions, including surgery and radiation to bone. And this is a dramatic example of a patient with extensive osteoblastic metastases by technetium bone scan. About 10 years ago, zoledronic acid was approved to prevent skeletal complications from prostate cancer. That approval was based on the results of 3 randomized controlled trials. This is the design of the randomized trial in prostate cancer. At the time, it was one of the largest completed randomized trials in prostate cancer, with 643 patients with castration-resistant disease. They were randomly assigned to placebo plus standard care versus zoledronic acid initially in 2 different dose levels. The primary outcome in this study was the proportion of patients who developed skeletal-related events, a composite endpoint that included many of those common clinical complications that I described on an earlier slide. These are the results of the trial. Compared to placebo, zoledronic acid significantly reduced the risk of skeletal-related events, and as I indicated in my earlier comment, this contributed to the ultimate approval of zoledronic acid to prevent skeletal complications in men with prostate cancer. The drug is also approved in other solid tumors and in multiple myeloma. This was really, perhaps not in FDA parlance, but in common clinical use, as part of supportive care. Patients received other standard anti-neoplastic therapies and received this bone-targeted therapy with the goal of preventing the complications due to their bone metastases. Progress in further preventing skeletal complications with the recent approval of Denosumab, also known as Xgeva. Rank ligand, receptor activator of kappa B ligand, is a critical mediator of osteoclast differentiation and survival. And Denosumab was developed and approved as the first therapeutic targeting this critical pathway in the osteoclast growth and differentiation. Denosumab is a potent inhibitor of rank ligand and results in dramatic decreases in osteoclast activity. It is approved in a variety of benign conditions, including osteoporosis. It's also approved now to prevent skeletal complications in patients with solid tumors. The approval in prostate cancer was based on the results of this head-to-head trial versus the standard arm of zoledronic acid. This now, I think, becomes the largest treatment trial in advanced disease. 1,870 patients with castration-resistant prostate cancer and bone metastases were assigned randomly to denosumab monthly versus zoledronic acid, and consistent with the design of the zoledronic acid trial, patients went on to receive other anti-neoplastic therapies, chemotherapy, secondary hormone therapies at the discretion of the treating physician. The primary endpoint was skeletal-related events, defined in the very same manner as in the earlier studies. In this randomized global trial, denosumab proved superior to zoledronic acid with a significant reduction in skeletal-related events. There was no increase in survival. Survival was not the primary endpoint for the trial, and so that's very fitting with the results of the earlier zoledronic acid versus placebo trial, where also no survival difference was observed. What I intended to do is comment on the relative differences between these two drugs, since we now have choices between zoledronic acid and denosumab. This is in the case of breast cancer and prostate cancer. Denosumab is proven superior to zoledronic acid. It is not known to be effective in multiple myeloma and is not approved for that purpose. It has no renal toxicity, but does share some of the other adverse effects of zoledronic acid, including risk for ONJ and hypocalcemia. So I wanted to be clear about commenting on those important issues. Prevention of bone metastases remains a critical unmet medical need. Many individuals in the field, including myself, perceive the castrate-resistant non-metastatic disease state as the optimal setting to prevent bone metastases. And the reason for that is it's a high-risk disease state and one in which you could accomplish clinical trials in a reasonable time frame at patients at greatest risk for developing bone metastases. Unfortunately, prior attempts to prevent metastases in this setting have been unsuccessful. Large randomized controlled trials of atrasentan have failed. Similarly, an earlier trial of zoledronic acid failed in this setting. In part, the failure of these earlier trials was the fact that although this is a high-risk disease state, the event rate assumptions were off, and the observed event rate was far lower than expected. And in fact, the zoledronic acid study was aborted for that reason. We looked at the data from that aborted trial and found that men with higher PSA or more rapid PSA doubling time had higher risk for adverse events, as shown in this slide. This is the data broken down in tertiles, showing that patients with higher baseline PSA or more rapid rate of PSA rise had a faster time to first bone metastases in this important disease state of castration-resistant disease without baseline bone metastases. And we used that data to inform the design of a successor trial looking at denosumab. This is the design of the denosumab metastasis prevention study. This is a global trial. About 1,500 patients with castration-resistant prostate cancer were randomly assigned to denosumab monthly versus placebo. We selected patients at higher risk for developing bone metastases based on a PSA greater than 8 or PSA doubling time less than 10 months. To allow patient and physician acceptance of the randomized design for bone targeted therapy, patients went on to receive other therapies at the discretion of the treating physician, recognizing, of course, that there's no approved therapy at this time in patients without established metastatic disease. The primary endpoint for this trial is bone metastasis-free survival. The first public presentation of the data will occur later this month, but what I can say is that this is a positive trial with a significant improvement in bone metastasis-free survival and significant delay in time to first bone metastasis. Radiopharmaceuticals have an established role in the symptomatic management of patients with castration-resistant prostate cancer and bone metastases. And Oliver Sartor, who will speak after me, has had a very important role in the development of some of these agents in palliation of advanced disease. What I'd like to do is take a moment and comment on some emerging data about Alpharadin or radium-223, because this agent has the potential to change our perspective of the role of radiopharmaceuticals. Until to date, radiopharmaceuticals have been viewed as part of symptomatic management or palliative care. They may have greater potential to, in fact, improve disease control, and improved survival, and that's what I'll briefly comment on. There are very important differences in the features of these agents. Strontium and samarium are beta-emitting agents which have a low linear energy transfer in a range of several millimeters. Radium-23, by contrast, is an investigational agent, large alpha particle with a high LET and short range of penetration. Really, a lot of the excitement about this agent comes from a small randomized phase 2 study, 64 patients with castration-resistant prostate cancer and bone metastases who had received local radiation therapy for symptomatic metastases were randomized to radium-223 every 4 weeks for 4 doses or matching placebo, and then followed for a variety of outcomes, including changes in biomarkers, pain, and ultimately survival as a safety signal. Here are the data for PSA and bone alkaline phosphatase, the latter being a marker of osteoblast activity. These are the waterfall plots showing that a substantial proportion of patients following radium-223 had a decline in PSA, suggesting an anti-tumor effect, something that we would not typically expect to see in patients treated with earlier generation radiopharmaceuticals. Even greater proportion of patients had marked decline in bone alkaline phosphatase, again a marker of osteoblast activity. So a very different change in bone and tumor biomarkers than would have been expected from earlier generation radiopharmaceuticals. And very provocatively, in this small randomized trial, patients treated with radium-223 had a longer survival. The observations of this phase 2 trial are now being tested in a large randomized phase 3 trial, about 900 patients with castration-resistant disease, being randomized to Alpharadin monthly for 6 doses versus placebo, with a primary endpoint of overall survival. And results of that mature study are expected as early as this calendar year. I'd like to conclude with brief comments on Cabozantinib, formerly known as XL184. As you heard from Eleni earlier, this is a dual inhibitor of VEGF receptor in MET. Both of these important pathways have a role, we believe, in normal bone remodeling as well as in the pathophysiology of prostate cancer. And the observations from the clinical trials suggest that Cabozantinib has an impact on each of these cellular compartments. Most of what we know about Cabozantinib in prostate cancer is derived from a large randomized discontinuation study that looked at 9 different disease cohorts, including prostate cancer. And I'll just briefly comment on some of the observations from that randomized discontinuation design and ultimately the broader clinical development plan of this agent. This is really what has garnered most of the excitement about this agent. Following treatment with Cabozantinib, most patients with bone metastases have dramatic improvements in their bone scans, including some complete resolutions of disease. These are sort of representative examples of patients pre and post Cabozantinib with marked improvements in bone scan as shown here in as early as 6 weeks. The results from the first 62 patients with bone metastases on the randomized discontinuation trial shown that 85% of patients have some level of improvement or resolution of bone disease, an observation that just we haven't seen with any other agent in this setting. This is not merely a bone scan effect, though. There are other very supportive data indicating activity. These are the effects of Cabozantinib on markers of osteoblast and osteoclast activity. These are the waterfall plots. Very dramatic decreases in both alkaline phosphatase and CTX. The magnitude of these changes is comparable, if not better, than you would expect to see with our best bone-targeted agents, which again have no impact on the underlying tumor, in contrast to this agent where we're seeing these effects on bone scan. It's also clear there are effects on tumor. This is best shown in this waterfall plot. These are the changes in measurable soft tissue target lesions, so this is outside of bone. And you see that most patients have a reduction in their measurable lesions. Although the response rate is low, less than 10%, most patients in fact have a reduction in measurable disease consistent with that direct anti-tumor effect. As was alluded to earlier, PSA does not appear to be a good marker of response with this agent. Changes in PSA following Cabozantinib are not well correlated with stability or improvement in measurable target lesions, changes in bone scans, or symptomatic improvement in bone pain. And that is similar to observations with other TKIs in castration-resistant disease. These very exciting early results have led to a broader development plan, and sorry if the slide doesn't project very well. The randomized discontinuation study observations, for the most part, were not pre-specified, and so we're expanding this study, the non-randomized extension, to pre-specify critical outcomes, including bone scan changes, symptomatic changes, and changes in biomarkers. The patients will be also more uniformly treatment refractory, having had to have failed at least docetaxel. And we believe the results of this rigorously conducted extension cohort will inform the design of phase 3. About 1/2 of the patients in the randomized discontinuation study required dose reductions because of toxicity, and that observation has led to our initiation of an investigator-sponsored trial to look at lower doses. If a drug results in improvements in bone scans in the vast majority of patients but has some toxicity, we believe there's probably room for a better therapeutic window at lower dose. And 2 phase 3 studies are now being designed to further evaluate the activity of this agent in prostate cancer. So with that, I'll conclude with the following observations. Bone metastases are a major cause of morbidity and mortality in men with prostate cancer. Zoledronic acid and Denosumab decrease the risk of skeletal-related events in advanced disease and are approved for this purpose. Denosumab increases bone metastasis-free survival. An ongoing randomized controlled trial will critically evaluate the impact of Alpharadin on overall survival. And early data from Cabozantinib, an inhibitor of VEGF receptor and MET, has shown a novel pattern of activity in prostate cancer that will be explored in future studies. Thank you.
Okay, questions? Ron.
Hi, Ron DePino. In the context of bone disease, has it been documented that the responses to the agent 184 is pretty impressive and broad? Has it been documented that MET is in fact activated or HGF is overexpressed in a large proportion of prostate cancer bone metastases?
So the question is it been demonstrated that MET is activated? Is it activated? I mean, do we know that it's a target of the tumor? I think the short answer is there is some information to suggest that this is an important pathway. No one at the present time can tell you or anyone that we know that it is inhibition of VEGF receptor and MET that in the tumor that are responsible for this activity. My best interpretation of all the data is that this, in fact, like that cartoon, that this agent has impact on the tumor compartment and bone compartment, may also have effects on the vascular compartment. It is likely that all of those activities combined are responsible for this novel profile of effects that we're seeing. It's hard to, so in a way, the way I think about this, since nearly all patients have this improvement in bone scan, I think the selection of patients for current and future trials is the patients with bone metastases, and that'll be the selection. So this is a different view on targeted therapy. This isn't like CML in the sense that we're not going to look for patients who have the rearrangement to treat with this agent. I think the selection will be patients with bone metastases.
And another Exelixis targeted therapy, 880, has a very similar spectrum of activity with respect to the targets. Has that also shown activities in bone disease?
So the rights to that drug are now with another company. They're not Exelixis, and I'm not aware of data of that agent in patients with bone metastases. I think there's relatively limited clinical trial data with that agent, and I'm not aware of data about it in patients with bone metastases in general or prostate cancer specifically.
Matt, isn't it true, though, that there have been other MET inhibitors tried in prostate cancer which have not shown noticeable benefit, I should say?
Well, I'm not sure that we know that. There aren't too many pure MET inhibitors. There are a number of agents that have been tried, and I would take that in a way as evidence that inhibition of MET alone is probably ineffective. I have no reason to believe that selective inhibition of MET would share this activity. We can be sure, I think, fair to say, that selective inhibition of some of the other pathways, including VEGF receptor, are not sufficient to confer this kind of activity. The closest small molecule TKI by profile of inhibition, actually, if you could go to the next slide. So here's what we know about other about TKIs in castration-resistant prostate cancer. So we have some data from phase 2 from Sorafenibu, Sunitinib, also now phase 3. And this is just my summary of what are reported to be the molecular targets. And you see that the main difference here is that you do inhibit MET. Sunitinib is pretty close otherwise. We studied this Sunitinib in a phase 2 trial in prostate cancer, saw a few bone scan improvements, very weak effects on bone, so quite a different profile of activity. And as you know, a phase 3 trial of Sunitinib failed, but I would submit the clinical data is dramatically different. The presumed target, the distinction appears to be primarily MET. We don't have detailed data about MET inhibition alone, and I don't think it would confer this type of activity.
Okay, we have time for one more question in the back.
Victor Moyo, has anyone ever tried to correlate the responses you see with that XL compound to other surrogates of long-term outcomes, such as circulating tumor cells?
So it's a great question. Given that PSA does not appear to be helpful or correlate with other indications of activity, we and others are very interested in looking at that very question, and in part of the non-randomized extension study, we'll systematically collect CTC information. Thank you.
Thank you very much, Matt.